Imaging, both qualitative and quantitative, are crucially important in the diagnosis of prostate diseases such as prostate cancer and benign prostate hyperplasia. Emerging prostate imaging technologies have become increasingly important in recent times, with imaging technologies such as MP-MRI and PET scans revolutionizing the way the prostate is viewed, while also increasing the diagnosis and survival rate of prostate-related diseases. Prostate cancer, in particular, is the second leading cause of death in men, with 1 in 5 males developing prostate cancer before the age of 85. So it is imperative that prostate imaging technologies and techniques continue to develop. Until recently, there was a lack of suitable imaging modality for the reliable detection of significant tumors in the prostate. In previous years, transrectal ultrasounds used during biopsies have been somewhat effective. However, some studies have revealed they can miss up to 20% of prostate cancers at the time of biopsy and frequently underestimate the grade of malignancy. This further expresses the importance of these emerging prostate imaging technologies.
Ultrasound uses sound pressure waves which are greater than 2 MHz. These pressure waves travel through the tissue causing vibrations, reflecting back a weakened version of the wave towards the transducer. These pressure waves, when interacting with the tissue, cause compressions and refractions. The time for the wave to travel back to the transducer gives the location of how deep the tissue is. Both these factors allow for an image to be produced. All factors that calibrate the system are the density of the tissue, propagation of sound in the tissue, and measured against the speed of sound. Magnetic resonance imaging uses magnetic fields in conjunction with radiofrequency pulses to produce a diagnostic image. The primary magnetic field produces a static field between 1.3 to 1.5 Tesla. This aligns hydrogen atoms within the body either parallel, low energy, or antiparallel, high energy. Gradient coils produce an additional magnetic field which alters the strength of the primary field. This changes the atoms to interphase and out of phase between slices, allowing spatial encoding. Radiofrequency coils transmit and receive a radiofrequency which flip hydrogen atoms from parallel to antiparallel. It also slowly changes the frequency, reverting all hydrogen atoms back to their primary state over time. This is called the relaxation phase. These signals are converted to digital for the computer system, making an image. Fusing both MRI and ultrasound gives optimal results for the patient. MRI image is performed first to map out the prostate and identify suspicious areas. After identifying these areas, ultrasound is used to get a further detailed image of the target area, giving information of the prostate cancer and its stage. This method is better at identifying the location of possible prostate cancer and how far they have developed. For PET scans, the patient is given a radioactive tracer intravenously. This molecule travels to the target location and is consumed by the tissue. Cancer tissue consumes FDG molecule in larger amounts. The positron molecule reacts with the electrons, destroying both particles, releasing 2 protons. These protons are used to detect the cancer tissue within the prostate. However, the secretion of FDG in the bladder can make it difficult in detecting areas of the cancer.
Exposure to ionizing radiation, coupled with a family history of cancer, can increase one's risk of cancer, states Miles et al. In his study of diagnostic radiation. Children and teens who receive high doses of radiation to treat cancer are more likely to develop additional cancers later in life. Recent technical innovations have contributed to lowering the radiation doses, and referring physicians should be aware of these innovations.
With the aforementioned modalities talked about, we will now have a look at the pros, cons, and the future of each technology, starting with ultrasound-based imaging. The advantages are that it is office-based, widely available, inexpensive, and has real-time imaging, with the disadvantages being that it has limited tissue contrast between cancerous and benign tissue. The advantages of MP-MRI-based imaging is that it has excellent tissue contrast for identification of clinically significant PCA, with the disadvantages being that it is expensive due to in-bore time, lack of real-time imaging, and requires advanced training. The advantages of MP-MRI ultrasound fusion-based imaging is that it is office-based and combines multimodality information. The disadvantages are that it is relatively costly, requires either fusion device-specific training or ample experience to perform cognitive fusion, and that registration errors during MRI ultrasound fusion are quite common. The advantages for PET-based imaging is that it offers ancillary information for tumor staging, characterization, and metastatic involvement. The disadvantages are that it is expensive and has technological and clinical challenges, such as attenuation correction and radiation exposure. Each of the modalities have exciting futures ahead, with the ultrasound-based imaging improving contrast, the MP-MRI-based imaging incorporating real-time imaging, the MP-MRI ultrasound-based fusion imaging improving in order to minimize registration errors, and the PET-based imaging developing specific radionuclides. Therefore, each modality has an exciting future ahead.